Hi, welcome to the NEET PG Core Revision series in Pharmacology, where I'll be taking you through the important topics for the upcoming NEET PG examination. So let's do today the drugs for peptic ulcer. So we are going to first classify the drugs which are required or which are used for the treatment of peptic ulcer. So we have first the drugs which are going to neutralize the acid secretion, then the drugs which are inhibiting or decreasing the gastric acid secretion, then the drugs which are going to protect the gastric mucosa, and then drugs used for management of H. pylori infection. So let's do them one by one. So we know that in the stomach, the gastric parietal cells are there and they lead to the formation of the gastric acid. So this is the hydrogen potassium ATPase pump, or also we call as the proton pump, and this releases H ions. It combines with the chloride acid. This is the hydrochloric acid form. So the drugs are going to neutralize this HCl. They are called as antacids, right? So we have here antacids. So we have magnesium hydroxide, aluminium hydroxide, calcium carbonate. Remember, these have certain side effects also as well. For example, magnesium hydroxide causes diarrhea. Remember, calcium causes contraction. Magnesium works opposite to calcium. So, if it is causing relaxation of the muscles of the intestine, it will definitely lead to diarrhea. And opposite to magnesium effect is of aluminium, and this leads to constipation. Calcium carbonate, if you take excess of it, it can lead to formation of the kidney stones. Right? So, this is made use of in which conditions? So, neutralizing or antacids, they are used in peptic ulcer and gastro-oesophageal reflux disease. Then we have drugs which inhibit or decrease the gastric acid secretion here. So, these are the most important drugs. So, we have this proton pump inhibitors here, PPIs. We have potassium channel blockers. We have H2 blockers. And we have anticholinergic drugs. Anticholinergic drugs. So, here we have pyrenzapine. Pyrenzapine. It is an M1 blocker, but because now better drugs are available, we don't really use them. So, this PPI and PCAP, both of them, they are going to target hydrogen potassium ATPase. One targets the proton part and the other targets the potassium part. So, they are going to work here. Then the drugs which protect the gastric mucosa, or they are called as the mucosal protective drugs here. So, we have sucralfate and we have the colloidal bismuth subcitrate. Now, for treatment of H. pylori infection, we require all these drugs, but alongside we will also require antibiotics. You have to add antibiotics to take care of the H. pylori bacteria. Now, moving on to the important drugs like H2 blockers here for us. So, H2 blockers, we have cimetidine, ranitidine and famotidine. So, famotidine is very potent drug, and it is one of the longest acting out of them. Longest acting. Now, cimetidine is associated with a lot of side effects because it can cross the blood-brain barrier. So, this can lead to hallucinations. It can lead to convulsions. In males, It can have anti-androgenic effect, anti-androgen effect, which can cause impotence, and it can cause gynecomastia, increases because it increases the prolactin levels. So we don't use cimetidine currently. That's one of the reasons. All right. Now, these drugs are going to block the H2 receptor. So they are mostly effective in taking care of the nocturnal acid secretion. So if someone complains of nocturnal gastric acid secretion, so they are more, or they are more, they are more efficient in that respect. So these drugs, H2 receptor blocker agents, they are used prophylactically to manage post-op aspiration pneumonia, right? So they are given preoperatively and they can manage the post-op aspiration pneumonia. Now there is a second or the latest generation of H2 blockers, second generation. We call it as, the drug is lafutidine. So it's a second generation drug. Now this has some additional actions, like it increases the nitric oxide production and it also increases the mucosal blood flow because of that, mucosal blood flow, right? And mucus production. So that's why this has additional effects and therefore can be used in peptic ulcer, it can be used in gastro-oesophageal reflux disease and dyspepsias, etc. Now this drug is only marketed and it is marketed in India, Japan and South Korea. Okay, so this is the second generation of this drug. Then very important and common drug group which we have are the proton pump inhibitors. So proton pump inhibitors, so these are going to target, we know, hydrogen potassium ATPase, and these are irreversible in nature, right? These are irreversible in nature. Also they are called as hit and run drugs. One of the hit and run drugs, irreversible nature. So they are usually given as an enteric coated tablet and taken on an empty stomach before breakfast, because food will, or you can say that they need to be ready before the food comes, before you take the food and the acid is secreted, because once the acid is secreted, then it cannot have any effect. So number one, we have to basically, because it targets basically the food induced acid secretion. So if you give it along with the food, then it will not be able to take care of the acid production, because see what happens is that, so when you give this drug, it doesn't have a local action. It will first enter the bloodstream and then through the bloodstream, it is going to go and act on this hydrogen potassium ATPase. Remember, these are prodrugs and they need activation in this parietal cell, and they get activated at acidic pH. Acidic pH. So they need acidic pH for activation, and then that active compound is going to block the hydrogen potassium ATPase. But all this process will require some time, around 1 hour. So if you give it along with food, what will happen? The acid will immediately be secreted because of the food, but this will not be able to have any effect. So it is given actually 1 hour before food. That is important, right? All right. So which of them is a fastest acting proton pump inhibitor? And we have the racer, which is rabiprazole. Rabiprazole. Racer is just to make you remember, R for race and R for rabiprazole. They are the fastest acting, rabiprazole. Drug of choice for almost all these conditions like peptic ulcer, gastro-oesophageal reflux disease, Zollinger-Ellison syndrome, then Barrett's esophagus. So in all these conditions, these drugs are the drug of choice. Safest in pregnancy is lansoprazole. Lansoprazole. Which of the following has minimum drug interactions? Again, we have rabiprazole. Rabiprazole. Most potent proton pump inhibitors that we have are S-omeprazole and dexrabiprazole. These are most potent now. Least potent is pantoprazole. Side effects. Now they have a side effects also because what happens is if you use them for a longer period of time, they will lead to decrease in the absorption of calcium and vitamin B12. So because of deficiency of calcium, patient will have osteoporosis. Osteoporosis. Deficiency of vitamin B12, that can lead to megaloblastic anemia. Then they can also cause hyperprolactinemia. Now, of late, warnings have been issued that if you use them for a longer period of time, they can cause chronic kidney disease. So they are damaging to the kidneys as well. Then yes, intestinal infections are more common because what they do, they increase the gastric pH. So therefore, there's more chances of the intestinal infections. The patient will have diarrhea and other issues of the GIT. Then gynecomastia, especially with omeprazole, it is rare, but yes, it can occur with the omeprazole. Now, very, very important is one of the drug interaction of omeprazole with a drug which is clopidogrel. Now, clopidogrel is an anti-platelet drug, right? And it is a pro-drug which needs to become active. So, clopidogrel to convert into this active form requires the enzyme CYP2C19. Now, proton pump inhibitors, especially omeprazole, it is an inhibitor of this enzyme. So, a patient on clopidogrel, if patient takes omeprazole, omeprazole is going to inhibit this enzyme and the activation of clopidogrel will not take place. Therefore, the patient will have failure of therapy with clopidogrel, right? So it predisposes that person to develop stroke or myocardial infarction. So here if you see, the safest drug out of the lot is that you can give rabiprazole. But omeprazole is absolutely contraindicated along with clopidogrel. So this is very, very important drug interaction. All right. Now, we have these new groups, which is the potassium-competitive acid blocker, or we call it as PCAB. So initially, we only had proton pump blockers, right, which targeted the proton part. So these drugs are going to target the potassium part of the hydrogen potassium ATPase. So how are they different? And these are called as prazins. So we have vonoprazan, rivaprazan. So how are they different is, number one, these are reversible blockers. Unlike the proton pump inhibitors which are irreversible, these are reversible blockers. They block both basal and food induced acid secretion. Proton pump inhibitors only blocked the food induced acid secretion. They will take care of the basal as well as the food induced acid secretion. They need not be given on an empty stomach, right? They have no interaction with food, just like unlike rather the PPI. So they need not be given on an empty stomach. So these are the differences between potassium competitive acid blockers and the proton pump inhibitors. So currently the use is only in case of H. pylori infection. That is on the primary use currently. Then we have the prostaglandin E1 analog, which is called as misoprostol. So remember, this is a specific drug for NSAID-induced ulcer, because prostaglandins normally they are protective because they help in synthesis of the mucus. So they protect the mucus layer, right? So they are going to form a protective covering, right? So they will protect the lining of the stomach. But when you give NSAIDs, they are going to inhibit the prostaglandin synthesis. So this mucus cover will be damaged or not formed. So if we see, they are going to help in the prostaglandin action. Misoprostol so seems like the very specific drug for NSAID-induced ulcer. But overall, if we see, the drug of choice for NSAID-induced ulcer is still PPIs. They are more specific, but the drug of choice is still the PPIs. The side effects of this misoprostol is that it can lead to diarrhea. So diarrhea is a side effect. Okay. Now coming to ulcer protectives. Now ulcer protectives like colloidal bismuth subcitrate, sucralfate. Now they also help in protecting the gastric mucosa. So what they do when you give these drugs, so you're giving these drugs, they form a polymer. They come together, form a polymer. And let's say here we have the ulcer. So they are going to form they're going to cover this by forming a polymer. So they cover this. So when there is acid release, acid will not come in touch with the ulcer, and therefore the patient will not feel any pain. So that's why they call as ulcer protectives. But remember, they need a pH. Again, they need an acidic pH. So pH less than 4 is required for polymerization of these compounds. Otherwise, they will not be effective, right? So this is very important to know. So these are used in, like sucralfate is used in peptic ulcer, colloidal bismuth subcitrate. This is used in quadruple therapy in H. pylori. So in H. pylori infection. Okay. Now this is a classical image based question we can ask you. So what is this adverse effect due to? This is a black tongue, and this is seen with colloidal bismuth subcitrate. This is the adverse effect. So this colloidal bismuth subcitrate can lead to black tongue, or it can lead to black tarry stools as well. So black stools, black tongue, all because of colloidal bismuth subcitrate. Then drugs for H. pylori. So what is the regime for anti-H. pylori drugs? So we have the triple drug regime, which is called as the CAL. You can remember CAL, CAL. In the triple drug regime, we have clarithromycin, 500 milligrams. Then we have amoxicillin, 1000 milligram, and lansoprazole, that the PPI, 30 milligrams. So all these drugs you use twice daily for 14 days. So most of the patients, they recover. But let's say the patient does not show any sign of recovery, then you shift to quadruple therapy. Quadruple means 4. So this was triple, this is triple, and then you shift to the quadruple therapy. That is 4 drugs here. So you L, B, M, T. So again, this is lansoprazole, This is the bismuth, colloidal bismuth subcitrate. This is an antibiotic, metronidazole. And we have another antibiotic, tetracycline. So these drugs, again, they are given for a period of 14 days. So if triple doesn't work, then we shift to the quadruple therapy. So sometimes they ask you which antibiotics are used for management of the H. pylori infection. These are the antibiotics: metronidazole, tetracycline, amoxicillin. They can be used. So in the anti-H. pylori triple therapy, let's say the patient shows hypersensitivity reactions or allergic reactions to amoxicillin, then we can replace that with metronidazole as well. So this was about the drugs used in peptic ulcer.